Good evening everyone, welcome to ENT. Now we're going to discuss about the differential diagnosis of membrane over tonsil. So what exactly is a membrane over tonsil or membranous tonsillitis? It is an advanced stage of follicular tonsillitis. So basically in follicular tonsillitis always the infection is spreading into the crepes of the tonsillitis, and the crepes of the tonsils are always filled with purulent material. All this exudation from the crepes will coalesce and to form a membrane type of thing over the tonsil. Differential diagnosis of membrane over tonsil can be divided into infectious causes and non-infectious causes. And again, under infectious causes, we have bacteria, we have virus, and we have fungi. Again, under the bacteria, we have acute membranous tonsillitis caused by pyogenic organisms, diphtheria caused by Corynebacterium diphtheria, and Vincent angina caused by Borrelia and fusiform bacilli. And under virus, we have infectious mononucleosis caused by Epstein-Barr virus. And under fungi, we have Candida infection. Coming to non-infectious causes, we have ulcers, we have malignancies, and we have a condition called agranulocytosis. Under ulcers, ulcers could be of a traumatic ulcer or aphthous ulcer, which is nothing but stress ulcer. And malignancies can be of malignancy of the tonsil itself or leukemia. So all the previous mentioned conditions will present with a membrane over tonsil, but it is this differentiating points which help us coming to a final conclusion of diagnosis. So in acute tonsillitis, we have easily removable membrane. In addition to that, we have typical features of acute tonsillitis like sore throat, dysphagia, and fever. Coming to diphtheria, Diphtheria we can see dirty grey tenacious membrane which bleeds on removal. In addition to that, there is cervical lymphadenopathy giving a bull neck appearance. On top of that, if we do smear and culture, obviously we'll see Corynebacterium diphtheria. In Vincent angina, unlike acute tonsillitis, it is insidious in onset, and membrane is only usually formed over one tonsil, and it is easily removable membrane, but after removal we can see irregular ulcer on the tonsil. And if we do a throat swab and culture, we can find either fusiform bacteria or spirochetes like Borrelia vincenti. Coming to infectious mononucleosis, here also we have generalized symptoms like very much enlarged, very much congested and covered with membrane tonsils, but lymph nodes in the posterior triangle of neck are enlarged along with splenomegaly, and the main attraction is that failure of antibiotics treatment. Infectious mononucleosis is caused by virus, Epstein-Barr virus, so antibiotics won't work out, and if we do a small Bunnell test, it would come as positive. Coming to Candida infection, we can see white adherent painless patches all over the mouth. So coming to aphthous ulcer, it can involve any part of the oropharynx, not only the tonsils. And here also we can see ulcers like in Vincent angina, but unlike Vincent angina, here it can be seen in any part of the oropharynx, not only on the tonsil. There could be small or alarmingly large, and it is a very painful condition, but even after all this thing, the total counts in complete blood picture would be normal. Coming to traumatic ulcer, any trauma to the oropharynx always heals by formation of a membrane within 24 hours after the trauma. So there would be obviously history of trauma either with some pencils or toothbrush or fingers, etc. Coming to malignancy of tonsil. In malignancy of tonsil, usually it is a unilateral tonsillar hypertrophy can be seen. Here also we can see ulcers which bleed on touching, but obviously this is a malignancy, so we can see hard palpable cervical lymph nodes. So in leukemia, always the total leukocyte count would be greater than 1 lakh per cubic millimeter, and progressive anemia can be seen. If we do a bone marrow aspiration examination, many lymphoblasts can be seen. And in the condition of agranulocytosis, always the total leukocyte count is decreased to a range of 2000 to even 50 per millimeter cube, and neutrophils, which are usually like 60 to 70%, would be reduced to 5% or even less. And there is ulcerative necrotic lesions, not only seen on the tonsils but also elsewhere in the oropharynx. So that's end the topic. Thank you.